We're proud to announce that today's webinar is a part of our Clinical Judgment webinar series titled Performance Scenarios, What is Your Role? Presented by Art Hsieh. I'm going to pass it over now to our presenter. Art, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Rio, thanks very much. And good morning, everybody. Hope everyone's well and hopefully is enjoying some reasonably good weather. I don't think that's true across the entire country, but I'm looking at folks who are popping in, and so far I think things are okay. My name is Art Hsieh. I'm a faculty coordinator for the Emergency Medical Care Department at Santa Rosa Junior College. And we're located in Windsor, California, which is about 70 miles northwest of San Francisco. And I'm also was part of the team of NIMSY members who helped to create this clinical judgment series. This was done in conjunction with the National Registry of EMTs and NIMSY to help bridge the basically how we've been teaching with the previous National Registry for ALS providers for paramedics and AMTs in our minds, and transitioning to the new TEI instruments and basically the new exam that is going to roll out come July 1st. So there's been two in-person trainings, and there'll be a couple of more, one in Illinois coming up this spring, and then the one at the symposium in Pittsburgh. In order for us to distribute this information as widely as possible, we also have been putting on parts of that workshop on these webinars. And so this is one of the parts that's here that we're going to talk about today. So in some ways, I'm super happy that we get a chance to spend an hour together on this information during the in-person training. This section is actually a bit shorter. So we'll be able to talk a little bit more deeply about some of the different tools to consider using, the assessment processes, ways to help promote your student to think about what, not necessarily toward the exam, but really toward that graduate entry level EMS provider that we all try our best to produce out of our programs. So just as a reminder, if you're not familiar with the changes that are happening, the registry is basically sunsetting the psychomotor exam, and but that's not necessarily directly related to the changes in the exam. The clinical judgment piece of the online exam, the computer adaptive test, is to help evaluate whether a paramedic or an advanced level provider can make clinical decisions and make them as accurately as possible, given the limited information that they receive during the course of a normal EMS event. By working their way through that process, this exam it's really to help improve the validity and reliability of the registry exam itself. It was very difficult for the registry to work with the psychomotor exam from that aspect. Just for any of us who've been doing the practical exams for a long time, we know that it's very difficult to create enough validity across exams, or reliability across exams, I should say. And so for the registry to continue maintaining its accreditation as a certification body, that really just had to go. On the plus side, the instruments that are being used now to assess students' clinical judgment is because of the way that the tools are being used. It's much more sophisticated, and it's at least in my opinion, much more accurate in terms of understanding whether or not that student that is trying to understand what's happening in the scenario that's provided to them. It's a bit more accurate in understanding if they can make the right decisions in the right order. And so I think it really does sort of work in that direction. So I'm sure many of you have seen this, and if not, you can find this certainly on the National Registry site. It's also included in a paper that was published by some folks from the registry to really kind of understand what happens during clinical judgment, what happens in terms of clinical judgment of that provider as they work their way through the call. And certainly there are, some critiques of this models, but the overall, it feels very closely like what actually does happen to that practitioner, how they receive their information, how they process it, and what they do. So from beginning, from dispatch to on-scene analysis and evaluation and implementation to after scene, right? And where that information continues forward, whether it's a transport to a facility or whether it's a refusal or whatever the outcomes are associated with a typical EMS call. So if you can sort of keep this in your head, this model, and I don't know, Rio, maybe it's possible we could maybe put a link into the chat so in case people want to try to grab it. This will help you to better understand how you can develop your scenarios, your simulations, your paper exercises, tabletops, so that it can start to mimic this out. And most of us already do this relatively intuitively with with our stations, with our skill stations or practice stations that we have, or in class that we. If you're using problem-based learning, this is really kind of one of the underpinnings of this model. But things like case studies and others that we'll talk about later on this morning all sort of follow in this particular direction. So you may already have some familiarity. This just basically helps to codify that information to help make it visible, and especially to your instructors who may be as needed instructors who basically come in and come out, and to provide additional information for them so that they are more deliberate in the way that they provide the training in order to help these students build that ability to do accurate clinical judgment. I will say that if you have questions during this process, by all means, we can certainly start with them in the chat. It's in the screen that I have right now. It's a little bit difficult to see if somebody's raising their hand. So unless Rio can see them, I probably will not be able to see them very well. So questions in the chat would I can see more easily. All right. Oops, sorry, apologies for that. That's my doggy. I'm working from home today. So this particular process, this particular part of the webinar series, it talks about roles. Who is involved in the development of curriculum and lesson plans and tools that can help promote the concept of clinical judgment? You might consider that to be a newer term related to critical thinking. Like we've used that phrase quite a bit over the decades, but now we're really kind of honing in on really what we're trying to understand, what we're trying to help our students build in the process of their learning, and how do we help bridge and help our students transition into the new exam so that they're better prepared for the task of taking an exam. So, and as you can imagine, it's not just one person, and it's going to be actually a multitude of layers of people that are involved in your program, all the way from your as needed instructors that come in to help do skill stations or practice stations, to your lecturers, to your lead instructor or assistant instructors that you have. Your clinical preceptors and your field preceptors are involved with this as well. And certainly over sort of coordinating all of this and supporting everybody as the program director and the medical director. So it's basically all levels of a typical paramedic or ALS provider training program. And so we're going to sort of talk about each one of them and some of the attributes that are tied to each one. So the rubber meets the road inside your classroom, right? So this is where we have the most amount of control. This is the area that we have the most amount of interest and passion to be able to deliver quality education. And we're out of, so this is where you start thinking about the things that you can sprinkle throughout the curriculum. And there's a variety of different ways. And the whole idea is to have students think, meaning really consider information and evaluate the value of that information, compare it to other forms or bits of information, and basically analyze and synthesize that to come up with some sort of response to a cue, right? The cue could be a question, it could be an action, it could be a reaction. It's just something to the fact that students are able to process information rather than just simply trying to tie facts and figures together. We to this day we still continue to have students do a lot of memorization of information. Students sometimes are under the impression, and we may push that actually unconsciously by, for example, drug drills, where we have students memorize an entire set of information, and we test that to see if they know the information by having them regurgitate all that information onto a blank form. And what does it say? It says that students can memorize that information, but can they actually use it? Can they actually implement it in a scenario or in a simulation, or be able to, in the middle of a class discourse on a case study, are able to pull in or push out that medication when the time is appropriate? And that might be a challenge, right? There's that transition that happens from pure memorization to application. And so it's not to say that they're wrong, or it's not to say that they're bad, but without some deliberateness of moving the information from a memory bank to a functional bank, that's where this work comes into play. So as you can probably intimate, teaching methods would include things like scenarios and simulations and case studies, problem-based learning, right? Again, these are in all of these examples, these are open-ended, requires participation at a couple of different levels, and requires quite a bit of decision making that needs to happen on the student's part. Your simulation, your scenarios may be super simple. They may be just 5 minutes long to start with, but they're constructed in a way that students can't just simply follow, for example, a skill sheet. And I start with step number 1 and I end with step number 10. And as long as I remember steps 1 through 10 in order, I'll pass this scenario. Right. Again, that's a memorization thing as opposed to an actual process thing. And you would know this, like if you would simply just change something in the middle that causes them to have to rethink what they need to do, and understand that it isn't just, I can't go to step 5 and 6. I may actually have to jump to 7 before I can come back to 6. Right. Just making simple decisions like that may already starts to help that particular process. And we do those relatively early, as that ability to be able to expand those scenarios and simulations so that they get more deep and more complex, and more sophisticated as the semester goes on, and more information is coming into their heads, and they're trying to really pull that stuff together. That's really the key thing to for just actively constructing these scenarios and simulations. Um, the probing questions, right? In these type of teaching methods, you build in probing questions. You want to be able to get to the crux of why in addition to the what, right? Tell me why you made this decision, or why do you think that this person went to the left when it should have gone to the right, right? The idea is that you have good, well-planned probe questions so that, and you have time built into your scenario so that when you are debriefing, you're able to really push on the student and the rest of the group that may be participating into deeper, richer discussions about what they did or didn't do, what they saw or didn't see, and really help to build that a huge amount of learning that comes out of what could be a relatively simple scenario. So I think that sometimes we don't give ourselves enough time to be able to look at we don't give ourselves enough time. Like, we focus on the physical part of the scenario, but really where most of the learning occurs in the debriefing that happens afterwards. Um, I use the three D words: discuss, debate, and discourse often. This is what I speak with my instructors. These are the buzzwords I want them to use. I said, I got to get you to have the students discuss. Yes, you are the instructor. Yes, you have the information. You're the expert. But to just lecture at the students after a simulation or scenario or during a case study, providing what you think about it, might feel terrific, but it doesn't really contribute a lot to learning on the students. You may be teaching, but they may not be learning. And so we train our instructors to make sure we have those questions listed out, the probing questions. Part of their goal for the day is to make sure that those questions are asked with each rotation of a station, that there is enough, they build enough time into their station so that they can really get at the 3Ds. All of this helps to encourage exploration, right? This is probably the most important part, right? We want to have students acquire the concept of lifelong learning, and the way to do that is to get them started while they're in the classroom. I'm going to give you I've got some information from you, and here it is. I want you to think about it. I'm going to ask you some questions about it. Other questions are going to appear that may not necessarily be directly related to what we see, or I will not be contained in the information that I provided. So I want you to go and find it. Right now, is that looking at a textbook? Is that going online? Is that whatever? Right. In our program, we encourage students to during these time frames, you take out your phone and you're going to look things up. It could be just simply, I don't recognize that home medication. What does that do? Oh, well, it does these actions. Oh, I wonder how this affects. Do you think that this medication could potentially affect what you saw in the scenario, right? So you can bridge these things in a way, and again, it doesn't take a lot of time, but it helps to build this concept of practicing retrieving information on the run. Multi-subject approaches. We teach in containers, right? That is something that we do. Hey, here's the cardiology section. Here's the respiratory section. Here's the trauma section. Here's the X, Y, and Z. And then somehow our scenarios happen to be cardiac scenarios and respiratory scenarios and trauma scenarios, and we sort of tie them from one to the other. There should be enough scenarios in which you're tying multiple topics together, right? So a multi-subject approach when it comes to building these cases or these scenarios is going to be important. It helps the student to not just focus on the information they have. So, for example, you might have three cases. You may present three cases to your class, and having them discuss in small groups, and then responding back to you in the large group format. And maybe that first one is specific to the topic that you're teaching. Maybe the second one is also, but maybe that third one reaches back to the previous topic. So, for example, if you're teaching cardiology, chances are you probably taught respiratory before then. So if you did, then maybe your third case has, oh, the 65-year-old woman who is complaining of shortness of breath with no chest pain. And they have meds built into their cases that include COPD meds as well as cardiac meds. And now you're asking them, give me some differentials on this patient. And now they have to think about not just the cardiac side, but they're also thinking about what could have been in respiratory. And maybe you take that case, and then after you've covered medical for a while, it represents itself, right? This is now, 2 months later, and we've taught most of medical, and now it's the same case, but now they can have even a bigger set of differentials to help explain that shortness of breath, right? The metabolic acidosis or the sepsis patient, right? So those type of build outs over time, one, I think it helps us because it saves a little time. If you're already pre-planning ahead, you can have these cases ready to go. All the students are going to do is bolt on additional information that you can have those discussions. You might do a little tweaking, that it sort of points in the direction of the topic you're teaching at that particular moment. But nevertheless, it gets them to dredge information up from the past and get it back to the present. And they can see that this patient is, in fact, their 30,000-foot view is the patient. They may be operating at 5,000 feet. We're just learning this part today, but overall, it helps them to contain that information. We'll talk a little bit about reflective essays in that next section. Again, meta-analysis, the idea of thinking about thinking is really crucial in both your hospital and clinic settings, as well as in the field. And here's where research in action comes to play, right? So if you the idea of EMS research, that's a little topic that we have to teach, and maybe we spend a little time, or maybe we have them read the section, and maybe we don't do anything more about that. Here's a great opportunity for you to have students practice research, right? Maybe not run the experiments, but they can learn how to really look for information in a accurate and rapid way, so that again, they acquire a skill that allows them to understand, like, hey, when I'm out there working and I'm by myself, I still have resources that I can reach out to, and that these are the places I'm going to go look for that information, and this is how I can retrieve it so that I can better refine my diagnosis or my differential process. Earlier, I had mentioned the assessment tools that we use, and the assessment tools that we have, it has to evolve. You may already be blessed of having moved your assessment instruments away from just cut and dry, just pieces of paper, only multiple choice, black and white type of answers, into more sophisticated assessment tools where you're really trying to, again, probe at this idea of clinical judgment. So, for example, if we're training people with scenarios, it kind of makes sense that we test them with scenarios. Now, building an assessment tool on a scenario is probably more challenging. It certainly is for me, like trying to understand, can I clearly define behaviors that I want to see in a student in which I can award points? And can I clearly define behaviors that I see in students that are incorrect, that I will deduct points, right? Or however you end up putting that together. It's not quite like a checklist, where checklists tend to have sort of an implicit ordering to them, and sometimes in a pure black and white situation. If those of us who have been field practitioners for a while know that in the real world, in the world of actual patients, black and white hardly ever exists. And so to build black and white exam forms or assessment forms doesn't seem to set up the student for that mindset, right? I certainly see that when we've seen forms that force students to make black and white choices, and then they try to apply the same logic to their patients in the field and scratch their heads when something doesn't go right. Those are, examples of where there's a dissonance, a disconnect between the classroom and then in the field. So using the scenarios for both formative and summative exam processes become increasingly important, again, especially as you move deeper and deeper into your curriculum. They should increase in complexity and duration, right? These scenarios should become longer chronologically. They should become more sophisticated. They should start, in other words, they should start to mirror real life, right? Your scenarios and simulations at the end of your curriculum should look different than the ones that you started with at the first day of the first week of class. I think most of us are using peer-to-peer critiques. That concept sort of evolved over the last, I would say, 7 to 9 years or so, where you get more of the team, and if your groups are arranged in squads that everybody participates. Not everyone is doing hands-on skill, but everyone participates because you have peer-to-peer critiquing going on in that group, right? So you have critiques that come from your instructors, critiques that come from the peers, and by training everybody how to do good debriefing critiques, really infuses that overall session with greater learning. So, and good decision-making processes. And when people make their mistakes, as they're apt to do, it becomes very successful because they can really break those mistakes down. People can help contribute to those conversations, and that's how it really works well. With the focus on the registry, again, there's sort of this little implicit assumption that, gee, if the National Registry is multiple choice questions, MCQs, we should be really focused on having students train on how to pass an MCQ exam. And a lot of instructors have moved away from essays and long answers and so forth, for that being one reason. The difficulty in grading them is another reason. There's several different reasons for that. I would suggest that that these other assessment paper-based tools, writing-based tools, are very effective in helping to formulate clinical judgment ability. It helps to remove that sort of black and white response that students are trying to do. Hey, I only have 4 choices. I know one of them is probably no good, so there's 3. So 3 kind of makes it's black and white or white. By having questions in which you're posing a question, you're asking for a response, it's harder work for you. There's no doubt about that. You have to be able to frame those type of questions. You have to be able to write those questions in such a way that it makes a lot of sense to the vast majority of people, so that you can feel confident that it isn't because they misread the question, and that you have to be able to provide the framework so that you can really evaluate that response through a rubric. So yes, it definitely takes as much work, if not more work, to construct them. But it gives the opportunity for the student to demonstrate to you that they are exercising that part of the brain. It's not just memory recall, but they've done the analysis, they've done the evaluation, and they've made some decisions based on that information. Non-MCQ exams could also include group responses, right? You can have students work out in squads responses to problem-based learning, right? So problem-based learning, where it's really a lot of vagueness, purposeful vagueness in the cases that you build to start with, to force them to do a lot of exploration and research, and that they can respond as groups. yes, you potentially again have potential problems with people, some people working, some people not working, but this is where you also have peer-to-peer critiques of their own work, where they give the students themselves in the squad are able to give each other participation points, right? And that you have it set up so it's done anonymously, so that it becomes really clear who's doing the work and who's not, right? It doesn't necessarily fail somebody, but then that helps to account for the that potential of somebody shirking their responsibilities. Um, a lot of pyramid students, at least in my part of the world, assume that the clinical time that they spend is really about doing IVs and delivering medications and, doing some brief assessments. And to me, that's not really a good use of their time. Yes, it's important for them to learn some of those technical skills, to practice on real patients, and work their way through that part. But we train our clinical preceptors that to really help the student the paramedic student that they see, help develop their clinical judgment skills. So to the way that we have ours set up, and I know this is not always possible given your environment that you're teaching in. We have a combination where students in the first part of their clinicals are just showing up and they're getting comfortable with the clinical site. They learn where all the equipment is. They do some of the technical skills. They do some observations and so forth. But then in the second half, they're tied to one or two clinical preceptors. They match their schedule, and then they will their primary responsibility is to assist that nurse preceptor, and that preceptor, their primary responsibility is to help the paramedic student do deep dives on the assessment process. So ask these questions. Have you considered this? Let's look this up. Do more of the care, do more time with the patient instead of bouncing around from one to another. It doesn't always happen, but when it does, we get high satisfaction um, ratings from the students who come back. The nurse preceptors feel especially good because they really do spend time. They really enjoy our paramedic students because this is something that, especially in the emergency department, where nurses are much more independent than in other parts of the hospital facility, they appreciate the level of responsibility that the paramedic is going to be assuming once they start practicing in the field, and they feel good about being able to help contribute to that knowledge base. So it is to really promote the learning beyond the EMS curriculum. If you have nurses who are really interested in the pre-hospital care field, I try to pull them in sometimes to help with developing cases, like in-hospital cases that gets tied to the field cases that we provide to students. So it gives them a greater knowledge base, things like, labs and imaging and some of the analysis that's associated with that. We try our best to have students, as part of their rotations, try to connect with the attending physician, and rotate with the physician for a couple of hours, to just see their thinking process, their decision process, what the physician is looking for when they're evaluating a patient. Again, just to not necessarily for the medical piece, not for the clinical stuff, but for the decision-making part, for the understanding, like how they're processing information. And then we finally have them develop these essays, these reflective practice essays. So our students are required to do a brief 1 to 2 paragraphs. It's amazing that our students will typically go 3 to 4 or 5 paragraphs if they've really had a good time, to think about what they saw, programs questions, so that they can really sort of address for themselves things that they saw, not just on the patients, but with the nurse preceptor, with the physician they may have rotated with the team, the ER team, how they function together. Again, to give them an idea about how decisions and delegation happen. Field preceptors. To me, personal opinion, This is probably the most critical piece of that speaks to the success of that student. Um, a good field preceptor, one that is teaching, the one that has skin in the game, takes the student that we have made, which is somebody with a lot of knowledge, some limited practice, some limited perceptions about patients based on clinical experiences, and now are working with real patients in the field, first in the experience part and then in the capstone. So during the field experience, really it's the preceptor that has to conceptualize um, and contextualize the knowledge, skills, and that clinical experience to make it so that it fits in the practice environment in which this student is going to be operating in the future. Um, the time, that one-to-one time that they spend with them is to help to expand on the why, right? Not just on you gotta just know this protocol, but why is that protocol used here? Why did you modify the protocol? Why was it important to maybe take things out of order from what you've learned in the classroom? What was the influence in the field? What was the environment that caused some what appears to be changes, but in fact, it's just the flexibility and thinking that's needed when you're not just working with a patient in the field, but you have to figure out how to move them. You have to figure out how to transport them. You have to figure out, location, right? So many more things that we as field providers have to decide that's beyond the clinical phase, right? They never really learn about that in the clinical phase. We may not really talk too much about that in the didactic phase. So this is where they have to make those type of decisions. The preceptors really, and this is why your preceptors have to be good. You have to know them. You have to really understand if they are clinically adept and that they have enough experience so that they can help your student develop patterns that are safe, right? All that we do are set in patterns, right? We drill them on patterns. Hey, primary assessment first, secondary assessment next, right? The OPQRST, the sample, right? We go through these routines right from the get-go, from EMR to EMT to AMT to paramedic, wherever your progression goes. And we drill them on all of these things because these are safe, acceptable practices, right? What we would call, quote, the standard of care, beyond just the medications and the procedures, just sort of how we do things. And we get to the field, and solid preceptors will say, that's your baseline. We're going to evolve that so that you can adapt it to any patient that you see and still accomplish that, right? Your inept preceptors will say, forget about what you learned in the classroom. Let me show you how it really works in the field, right? That dissonance doesn't work well for the student, right? You've spent months trying to help them build solid processes. And so to have a preceptor take your legs out from under you by saying those things is not helpful, right? And you can help prep your students by letting them know about those type of situations. You may not be in a position to choose your preceptors. I get that as well. We have a combination of both able to choose as well as some departments that we're not, but it's the reason why we go to the field, why we do monitor our students in the field. We don't leave them alone. And it isn't because we're worried about the student. I'm actually not, if I send a student to the field, I'm not worried about them. They'll figure it out. I'm not worried about it, right? What I am worried about is a preceptor who I don't know, and I don't know what they're saying to the student. And so my rides out there is to listen carefully, to watch the interactions between the student and the preceptor to make sure everything is hunky-dory, that it's kosher, that the right things are being said. And for the most part, they are. I mean, it isn't like it's a disaster all the time. But if we do see somebody, a preceptor who's not sort of towing the line of good acceptable practice, that's just somebody we're not using again. And we provide that level of feedback to the preceptor, either directly or through the department. So for those of you who are program directors, right, consider that preceptor orientation and training is a key part of your standard for accreditation. It's important to understand that it isn't, don't just give them a video. Please don't just give them a manual, right? There's just, those things are cut and dry. They don't provide the information that you really want to get to them. Right? Don't just talk about, this is how you fill out a form, right? That's not an orientation. That doesn't talk to you, that doesn't talk to the preceptor what you as the program want to have happen. You want to be able to, again, construct learning environments that continues to contribute to the development of clinical judgment, right? This is where, again, the rubber meets the road. This is where if it's going to happen, it's going to happen here, right? And it's going to happen. You want it to happen with the right preceptor. You don't want it to happen in despite the preceptor, right? So, which sometimes happens. I get that. Um, where does your medical director fit in on this? Your medical director is responsible for the clinical relevancy of your entire program, right? And we know that, right? We have them sign forms, we have them sign curriculum, and they come in. Some of our medical directors talk with our students, they teach them, they interact with them more intimately. Um, so all of that is sort of a given, right? These days, most programs have evolved into at least having that as the baseline. Um, do recall that your medical director has at least a decade of education and training under their belt. If they've been practicing as an ER physician, they have tons of experience in terms of clinical judgment. If they are an EMS fellow, they've got even more targeted information about EMS providers, right? So it just depends on who your medical director is. But they are there to help not just sign things off, but to do the things that you see on the screen. Make sure that the stuff that's being taught has clinical relevancy, that they can provide enhancements to the content, and they can help encourage exploration. God knows these days physicians are constantly in front of their desktops. They're sitting at the ER looking up information about specific disease processes and other stuff as they're evaluating their patients, because there's just too much information to try to recall. So just helping to encourage exploration, giving permission to a certain extent that it's okay not to know something. What's not okay is not to admit it. That's where your medical director can really help you. They should be let me rephrase that. The standard doesn't really call for it. So, but I'll say that as an educator, my relationship with my medical director is I encourage my medical director to really be the primary evaluator of readiness to practice, which thank God I have a medical director who loves doing this. So he is the person that drives the summative exam process. Right. I set up the simulation, I set up the scenario, but he's the one that is watching, asking questions, and observing that student to see whether or not they're exercising good clinical judgment. We tell the student there isn't a right or wrong answer to the simulations that they have. They're not looking for anything that's correct. What we're looking for is their ability to think. And that's what my medical director really looks at. And so, because we certainly have had students who've not come to the right conclusion, but are able to defend what they thought about when they realize what they missed, and are able to be able to come forward and think about what they would do differently the next time, right? So however you construct your summative exam, if you're able to wrap in your medical director physically, great. If you can't do that because of time and contract constraints, have them at least involved with what do you want the student to show to leave that you're willing to sign on, even if you don't see them, right? So having those discussions, I think, are really important, and getting them involved is really key. Program directors. So what do we do? Well, some of us are lead instructors as well. Many of us are, or we do a lot of teaching, so we have that hat that we wear. But the other hat is really about making sure that the entire program is focused and that it is producing what you think it should be producing, right? What your advisory committee tells you it should be producing, this magical unicorn of a graduate entry level paramedic or ALS provider. And so it's things like making sure that the pedagogy, the process of teaching matches the curricula at the appropriate times, right? Not throwing students into the deep end on one end, or not, or not throwing them into the deep end when it's appropriate, right? So, and those are all processes. Those aren't decisions that are made on the fly. Those are things that are deliberately decided upon through either your role as a lead instructor or as the program director. You want to make sure that the tools and the assessments that you do are appropriate during the times of training. All right, that learning environment has to be as good as you can get it. Most of us work with very limited resources. So, basic things. Is there heat in the classroom or air conditioning? Is there enough space to do some practice? Is the equipment up to date? Is it related to what's in the field? Or is it like, 25-year-old monitors that don't even exist anymore, right? So, do you need to reach out and learn how to do CETIA grants or to do Perkins grants or to do workforce grants? Do you need to advocate and you have your advisory committee advocate for better space, better location, expansion of a program, or limitations on the number of students, whatever it might be, but your role is to make sure that your students that are in your class who are trying to learn this challenging job has the most optimal environment for them to do it in, right? That to me is really that's my role as a program director, is to make sure, right? My heels are held to the fire every 5 to 7 years with a reaccreditation visit, and I have to be able to demonstrate not just on paper, but in reality that we're doing the things that optimizes learning outcomes. Do you advocate for instructor support? Do you advocate for your instructors to get an educator continuing education? Do you encourage them to join NEMSI? Here's a little plug for that. Do you encourage them to do more than just show up? Do you provide information to them before they come to teach in the classroom, so that they are prepared? Do you offer free CE? Right? Again, just how do you tie your instructors who may not be full-time faculty or even part-time faculty, they're just skills instructors? How do you tie them, provide some loyalty so that they are wanting to help the program and the students really learn the information the way that you want them to? For the students, right? So at the end, at the very baseline, right, do the students get all the support that you can provide? Maybe not you personally, but you're the conduit for things like financial aid, for disability resources, for the library, for the 1001 support services that can help students who are struggling. They may have the aptitude, they may have the attitude, but they don't may not have the capacity to successfully get through their program. But if you're able to provide support structures for them, that allows their attitude and aptitude to really function, right? That's that level of student support is crucial, right? We are most of us are experiencing a shortage of paramedics in our area. We have a lot of pressure to put out bigger classes, more frequent classes, more paramedics in the field. Right. Whether that's right or wrong, that's not the point of the argument. It just is what it is. So we may be accepting more students and that our current support systems may not be able to accommodate. And so how do you get around that? How do you help set it up so that you can maintain the quality of the program, despite the pressures to generate more folks? All right. let me check my time. Bullseye. So, um, hopefully you have the sense that in terms of the roles that people play, it really is that teamwork, right? It is all of us who are in within our training programs to be able to work toward this idea of helping to develop clinical judgment, right? Yes, I don't want to intimate. Please make sure that you understand that I'm not intimating that this is the only thing that we do. It's not true at all, right? Yes, they have to learn how to do skills. Yes, they have to learn how to be professional and empathetic and compassionate. And yes, we have 1,000 other learning objectives and scores of student learning outcomes that we have to accomplish. So all that is true. Right. But when it comes to the idea of clinical judgment, all of the stuff that we've been talking about for the last 15 minutes, the idea is to be able to help move the needle forward on developing this most crucial part of the, as far as I'm concerned, the field care provider, the ability to make decisions based on the knowledge, based on the information that they've been trained to retrieve and have been trained to use and evaluate and come to decisions with, right? So much of the job that our folks are doing is all about learning what not to do in most situations, right? The idea of throwing the kitchen sink is the thing that we are trying to avoid in these type of situations. So um, everyone has to contribute toward that, right? Everyone from your line instructors to your lead instructors to your preceptors to your medical director to the program director, they all have to work in concert to make sure that there's every opportunity for students to learn this in their training. Um, remember that our students, unlike law enforcement, unlike fire technology, unlike nursing, our students are often responsible for their patients on day one of their job, right? So that might mean they are going to run that status medicus. They may run that cardiac arrest. That may be the first call that they have in their career, and they are expected to perform on that call, right? So we've got to be able to make sure that we can be assured that the students can exert and exercise that clinical judgment when they have to do that particular event. One quick plug for the EMS Agenda 2050. If you've not heard about this, I'm not sure if you're familiar with the EMS Education Agenda from 2000. NIMSY was one of many associations and organizations that were involved in developing the education agenda in that time frame, and that agenda is now being revised. There has been a call for information by NHTSA over the past several months that's going to close on the 31st. But if you they were requesting comments, and if you haven't given your comments yet and you have some comments about the agenda, what you might want to see, what you think has happened over the last couple of decades since the release of the first agenda, you have basically a week or so left to be able to put that information in. Your NEMSI board members have already put together a series of responses, and those were sent to NHTSA probably about a week or so ago. So your association has already made its comments, but they are also looking for individual comments as well. There's a lot of things have happened in the last 20 some odd years in terms of EMS education. And then there's been a lot of things that have not happened despite the agenda. So we're looking to see where we need to go next in terms of helping to build the structure that allows us to make those entry-level practitioners even better than what they are today. I will stop here. And I'm gonna just see if there's any questions. which I don't see. Rio, would this be the time for people can unmute if they have a question?
I don't believe we have that setting on right now for that ability,
Okay.
but if anybody
Okay.
has any questions, they can definitely type them in the chat. Might be a little easier than Q&A.
Okay. Thanks, Robert. Appreciate the kind words. I don't see anything coming on, Rio, so I think we're going to be done for today.
Okay. All right. That sounds great. Thank you so much, Art, again, for being here with us today and sharing your knowledge. We always appreciate you. Everybody,
Opportunity.
I did put the link to the CE in the chat, and I will be sure to include that in tomorrow's follow-up email as well. So with that, we will go ahead and conclude, and I hope everybody has a fantastic rest of your week. Thank you.
Thank you.
Bye.